Good morning, all, for coming for the breakfast session. So, drug-resistant epilepsy is one of the most important topics that every pediatricnologist should be aware of. So, we have three eminent speakers. We will try to conclude at 8:30 p.m. So, starting
AM.
with 8:30 a.m. Sorry. So, starting with our first speaker, Dr. Ahmed. He will be
Sorry.
speaking on
We'll
indications.
just jump straight onto it. We're already a bit late. Thanks very much for inviting, and thank you all for making it this morning. I heard it was quite a wild night last night. I have no disclosures. A lot of the things I'm going to say in the beginning have already been said many times by many speakers. So I'm just going to zoom through this. Epilepsy surgery, just remember Dr. Hassan Musa's talk. Three questions. Is it needed? Will it work? Is it safe? You want a bit more detail. It's all there. Um, but and you know all this. You need a video EEG. You need good imaging. But the point I want to make is how much investigation done will vary between centers, and would depend on how confident one is about achieving the goals of the pre-surgical workup, which is to identify the epileptogenic lesion, to define the region that you need to resect for surgery, and to assess whether in doing so you will cause any harm or not. This was a good paper by the Task Force for Pediatric Epilepsy Surgery, and just a few points to highlight. For certain lesions, such as developmental tumors, uh, most centers felt that having video EEG would be nice, but it's not mandatory. So you can go with just the lesion and concordant seizure semiology and interictal EEG. For hypothalamic hamartoma, some centers felt that video EEG was of little use or unwarranted because most of the time you don't get very nice ictal rhythms because the lesion is very deep. And invasive EEG monitoring usually is not necessary when there's a clear lesion and concordant data. They followed up with another paper showing what are the indications of intracranial EEG. And you've seen lots of stereo EEGs presented already this morning. So I'm just going to jump straight into some case examples. So this was a 9-year-old boy with seizures from the age of 7 years. Most of the seizures occurred during sleep. They were mostly hypermotor seizures, initially poorly controlled on levetiracetam, but when he was started on carbamazepine, he became seizure-free. And I think you've seen these images already, or at least similar images already. There's a bottom of sulcus dysplasia over the left middle frontal sulcus. You can just about make the tail there. Hang on, let me just. There's a small tail there. And it's a hypometabolic on PET. So seizure-free on carbamazepine. Now, question is surgery indicated? And we've heard from Dr. Hassan Musa yesterday, you don't need to be having seizures, ongoing seizures, before you're considered a surgical candidate. And this paper, again, I'm quoting, that a surgical referral should be considered even in patients who are seizure-free on anti-seizure medications when they have a brain lesion that's in non-eloquent cortex. And this is what the boy had. Would you do any other tests? In my center, we're happy. You've got a nice, you know what it is. It's a BOSD, and most BOSDs are just single lesions, except if they have a genetic condition, which is quite rare. You've got concordant EEG, seizure semiology, and the PET is also called there. And so this boy went ahead to have a focal resection, ECOG guided focal resection, and he became seizure free. Now, this is the second case. There's a younger boy who was diagnosed antenatally with hydrocephalus, but the postnatal scan confirmed that it was a left cerebral malformation. He had seizures from 4 months, and they were focal seizures. He never had any spasms. And the seizures were not too bad in the first few years of life. But from 5 years onwards, he had almost daily seizures. And they were a mixture of focal seizures as well as what sounds like tonic seizures, where he would have some stiffening and drop. He has some a mild right hemiparesis. The serial EEGs showed an initial normal EEG and focal EEG at 4 years. But when he came with at 5 years with all these worsening seizures, he had lots. He had nasty looking EEG, lots of bifrontal spikes and polyspike waves. You can still see focal slowing on the left. And he also had this electrographic seizures over the left occipital region, which were quite impressive. This was his seizure. So he stiffens a bit at the beginning. He turns around. And he looks into the camera, you will see blinking over the right side. I think mom kept checking. He was a bit off. But you could see as the seizure was going on, quite localized rhythms over the left frontal region. And he's out of it. And this was his scan. The most abnormal part was this central region, which looks like a heterotopic area, but the whole left hemisphere did not look normal either. And on the PET scan, where the heterotopic area was, it was ametabolic. Where there's a hypointense rim on T1, there's significant hypometabolism on the PET. But the whole left hemisphere was also a bit down. So questions, is he a surgical candidate? What additional investigations would you do? And what would be your surgical approach? This was discussed quite extensively with lots of people, including Simon Harvey. In the end, we knew that if we wanted to cover all possibilities, the best surgery would be a hemispherotomy. He's got abnormality diffusely on the left. He's got electrographic seizures right at the back, and now the EEG is very bad. But he's not too bad neurologically. He's walking. You don't want to give him a hemiparesis. So in the end, we ended up with just doing a very focal resection, just at that rim where it's hypointense on T1 and hypometabolic on the PET scan. And that's what we did, and we were lucky. He still has some very mild blinking, but his EEG normalized, all the bifrontal abnormalities, the electrographic seizures went, and he didn't have any additional neurological deficit. Oops. Okay. Now, the final case I want to show is of this girl who had seizures from about 5 years of age. She has some sort of aura, and then she'll have this right-sided stiffening and impaired awareness. I might actually just play the video. But the most important history is that almost all her seizures will be triggered by loud and high tempo music. And I don't know, can we have sound? Because, okay, down a bit. So gummy bear is one of the most consistent triggers for her seizures. So when we played that, thank you. That's better. Now she's starting to have a seizure now. You'll see her mom removing the mask in a while. So she's already a bit off. Maybe just some automatic movements of the mouse. He doesn't answer when called. And you see the right arm dystonia. And we recorded similar seizures on video EEG. You can, you can see, yeah, you can see right at the top there, play Gummy Bear song, and then she starts to have a seizure. And the seizure was associated with the ictal rhythm over the left temporal region. We did 3T MRI, we could not find anything. When we did a PET scan, she had subtle hypometabolism in mainly in two areas. One in the left mesial temporal region, and another in the left superior temporal gyrus. So she has a musicogenic epilepsy. There's a difference between musicogenic and audiogenic seizures. It's usually a bit later. So in fact, this is my first case of musicogenic epilepsy, actually. But if you look at the literature, some musicogenic epilepsy do have localized focal abnormality. And on intracranial EEG monitoring, people have localized it to several different regions. It could be in the mesial temporal region, it could be in the right superior temporal gyrus, and some have done well with surgery. But I think whenever you have a musicogenic seizure, you should always check for GAD65 antibody. And this is now very well described. And if you are antibody positive, usually you don't do so well with surgery. And in fact, this girl had a positive antibody. We tried several we tried several immunotherapy, steroids, IVIG, some higher stuff, but didn't respond very well. And we just don't know what to do with her at the moment. So I'd be grateful if any of you have seen a similar case, and we can discuss. So that's about all I have to say. In conclusion, remember the 3 questions. Is it needed? Who wants to say what the 3 questions are? Anyway, you all know this. Dr. Hassan is at the back there. If you don't remember, you should have a rational use of pre-surgical investigations, really understand the epilepsy syndrome and substrate, and pragmatic. I hope you can, I have shown at least one example where a pragmatic approach to surgery is sometimes useful. Thank you very much.
Thanks, Dr. Ahmed. That sets the stage for further discussions. May I know what was the titer in your case, anti-GAD titer?
Oh, there's no titer.
Okay.
When ours, when we tested, it was just high. Yeah.
Okay, thank you. So we'll have some questions at the end. So now I call upon Dr. Lakshmi Narayan Kannan. He's an eminent pediatric neurologist and epileptologist from Chennai. So he will be speaking on recent advances in epilepsy surgery.
Good morning, everyone. Straight away, we'll start. So I'll just touch upon some of the recent advances. So why epilepsy surgery? Yeah, this is one of the important data. So for some of you who are pediatricians or pediatric neurologists, so this data basically is a large population pooled adult data, okay, about 23,000 of adults, retrospective study. What they found, very interestingly, the standardized mortality rate of about 9.4% for those drug refractory epilepsy patients managed by non-specialist care. Okay, when the general neurologist manage, it is almost half, 5.6%. But when the epileptologist or comprehensive epilepsy program multidisciplinary team manages these patients, it is nearly 1/4, 2.8%. Okay, so this means all drug-resistant epilepsy patients, even in adults, should be managed by specialized epileptologists. So you can extrapolate the data for the children. So we need to refer these patients early, because even in the best of the centers, even in US, the literature says about 18 to 20 years of delay happens when the patient lands in the epilepsy surgery program, when they are be curated by epilepsy surgery, when they can be cured by epilepsy surgery. So similar data, another study, again, reiterates the same point. So for those who underwent surgery and became completely seizure-free, the mortality rate is much lower compared to those who did not undergo surgery. So we do surgery for children with drug-resistant epilepsy, lesion present in the region that can be safely resected. without causing any disabling deficits. Lesion that needs removal on its own, or the patient family informed of the risks involved and give a informed consent. So it's the best treatment option for a well-defined lesion that is removable, that is the cause of the epilepsy. So the most important thing is careful case selection. Already Ahmed has reiterated this. So just to point out what are the recent advances in the epilepsy surgery, because epilepsy surgery has been happening for more than a century now, started from UK and a lot of other European countries, US, and so more difficult cases are now being operated. So that's the number one point I would say. All over the world, in most of the epilepsy surgery centers, nowadays we operate more and more difficult cases, complex cases that wouldn't be operated 5 years ago or 10 years ago. And more younger children undergo surgery, infants as young as 3 months or 4 months are undergoing epilepsy surgery, including hemispherotomy. Because the surgical standards, the techniques have been standardized, the pre-operative, post-operative, intensive care treatment has been well standardized and protocolized. So that is important part. More patients with multilobar lesions, bilateral lesions, and MRI negative lesions, MRI negative patients undergo epilepsy surgery now. So this is the most difficult part previously, but nowadays more and more with the advance in the multimodality imaging and the integration of the data, these patients are able to undergo surgery successfully as well as become seizure-free. Increasing number of stereo EEGs are performed in India and all the other countries as well. Limited focal resection is the norm now. We don't do any wide resection anymore. We do very focal resection. Most of the kind of images that we have been seeing, bottom of sulcus dysplasia, that needs a very precise focal resection of the lesion. Minimally invasive is the way to go. And in that, two main forms of treatments are radiofrequency thermocoagulation and laser interstitial thermal therapy. At the moment, we don't have laser interstitial thermal therapy in India. So we do radiofrequency thermocoagulation in many centers across India and across the South Asian regions as well. So I'll show you some cases. So this is a 10-year-old girl presented with unprovoked seizures by 3 years of age, explosive onset nocturnal seizures, and had a sudden arousal from sleep, looking confused, unresponsive, restless, salivation at times. So I'll show you a seizure. So she arouses, looks straight to the left, restless, kicking her legs, sits up, unresponsive. Actually, she moves more left hand than right hand. Unfortunately, the right hand is held by mother, but you will see in a second that right hand is postured actually. Now, if you see, the right hand is less mobile and postured. The left hand is free and moving. And she keeps looking to the left. So this kind of seizure, she would have almost 10, 15 every night, explosive onset from the beginning. And this showed left frontocentro-temporal intraocular epileptiform discharges as well as the ictal rhythm were in the left temporal region. With that, we were kind of hypothesizing possibly this seizure focus is in the left insula because these were nocturnal sleep-related hypermotor seizures and with these lateralizing features and diffuse frontocentro-temporal, both supra and intrasylvian dipoles in the EEG. So these all indicate possible insular epilepsy. But the MRIs have been reported repeatedly normal over many serial MRIs, including harness protocol MRI 3T. No definite focal lesion was found. But the important aspect of this patient is the PET scan came into the rescue. So if you see the PET scan, so the left insula, where the left insula, the right side you have activity in the insula, but the left side there is completely a metabolic hole in the left insula. And this is MRI PET co-registration again showing the whole of the left insular gyrus from anterior to posterior. It is very hypometabolic, you can see there, right? So this is the one investigation which helped her the most. So with that, we kind of possibly this is a type 2 dysplasia, which is occult, MRI negative but PET positive. So we have the options focal resection, we can go for the direct surgery, or we can localize further stereo EEG, and radio frequency thermocoagulation was available with us at that moment, but it is whole of the insula. So at that moment, we were not sure how much to coagulate and what all the region, and we thought it would be not complete, whole insula cannot be done at that moment. So laser interstitial thermal therapy was not available to us in India. The problem with, if it was a right insula, we could have thought more about direct surgery, but the left insula is tricky, and most epilepsy surgery centers in the world wouldn't do insulectomy or insular resection in the left side because of the risk of stroke and language dominant network, language dominant hemisphere. So there's high risk of aphasia. So we explored her with electrodes, mainly in the insulotemporal, mainly for language, language stimulation and language mapping, as well as for extent of the resection. We know that it is in the insula, but from where to where you have to resect, that precise surgical resection margins are needed to be defined precisely. So these were the electrode positions. You can see there are 3 electrodes in the posterior superior insula, and 1 in the anterior superior insula, 1 in the middle insula, and 1 in the inferior insula, right? And there are 2 electrodes in the Broca's area and a few electrodes in the posterior superior temporal gyrus for the Wernicke's and language network. So she had a very focal seizure onset here in the anterior superior and posterior superior insula, and these were the distal contacts which were there in the insular cortex. And there were further posterior electrodes within the insula that were not showing seizures. So this was a focal onset and restricted to the anterior mid-insula. Further posterior-most extent was not involved. So just to summarize the stereo EEG findings, this anterior superior insula here and the mid-insula, these were the ones that caused the seizures. We thought this is the primary and possibly this is a early propagation zone. But the posterior-most part of the insula was not involved. Why I am emphasizing that? Posterior-most part of the insula is the more risky in terms of the vascular anatomy to reach there and to operate, and that increases the risk of stroke. So we don't want to be in the posterior insula as far as possible. So this is the final resection. So we have done the anterior and mid insula, and we have left behind the posterior most. You can see here in the sagittal very nicely, the posterior and the inferior insula is left behind. So this was a FCD type 2A, which are more known to be occult, completely seizure-free for more than 3 years now, off medications, regularly attending school, no neurodeficits. She had mild dysphasia for a couple of months and had a mild hand weakness, which is due to the insular resection itself. It is not due to any vascular complication. So that all came good 2 months. So now she is completely normal, no neurodeficits at all. On the other hand, this child, this is another patient, this child had multiple nightly seizures since 8 years of age, went as MRI negative, serial MRIs showed MRI negative. From the beginning, we knew that her seizure focus in the video EEG electroclinically was in the right frontal, near the right frontal ice field. We knew that. But finding that occult dysplasia was the problem. Initially, it was all bit occult and negative, and multiple scans were reviewed with the information that you have to look for in the right frontal. So, but it was all negative. But after multiple 2 or 3 sets of investigations, video EEG over the years, it remained the same, single stereotyped seizures from that same region, and MRI PET we did 3 times. So finally, at the 3rd time, recently, we found this bottom of sulcus dysplasia here, exactly where we were looking for, right? So the moment you identify this lesion, the whole paradigm of treatment planning shifts. The previous case, we didn't, after multiple reviews also, we didn't have the definite lesion. So we had to go ahead with stereo EEG and invasive EEG monitoring localization before we can resect the area. But this case, once we had the identified the bottom of sulcus dysplasia, which is very focal, but the problem was it was just in front of the motor cortex. Okay, So I'm not showing the sagittal, but it was, see, this is the motor cortex and the lesion was just in front, actually abutting the motor cortex. The posteriormost, this triangle was abutting the motor cortex. So that was the difficulty in this patient. So operated single stage with intraoperative electrocardiography. And we did a MRI immediately after the surgery and found that a small bit of this triangle was left. So immediately we taken up again for the re-exploration and just removed that bit of triangle there within the pre-central gyrus motor cortex, because we knew that if we just leave that behind, she wouldn't be seizure free. Because in these kind of cases, the complete resection is the one which offers the seizure freedom. Okay. So these are the types. So we did find the lesion, we did the resection. After the initial resection is over, after we resected what we planned, we did a MRI. We don't have an intraoperative MRI. Many of the centers in the Western world will have intraoperative MRI. The MRI machine is just next door in the operation theater, and the MRI machine is drawn in, and you get the MRI. And then, but here, what we did, India Jugaad. So we closed the craniotomy. We took the patient same floor in the MRI, and we did the MRI and found that there is a small piece of the this part, posterior most part was remaining. So we took her up again in the operation theater, opened the craniotomy, completed the resection, came out. Now for 4 months plus, she is completely seizure free. Before that, multiple daily seizures. Now 4 months completely seizure free. So I'll just complete with this TSC case. This is a case of tuberous sclerosis, 7 years old, diagnosed as at birth with the head drops and staring episodes since early infancy. Infantile spasms since 7 months of age. And she had autism, no speech, no communication skills, multiple medications, failed everything. So the single most important point in tuberous sclerosis is you have to find a focal slowing and focal rhythmic spiking. Okay, so I'll spend 1 minute here. So this is what we used to call EKG-like spikes. So I learned this in Melbourne, Royal Children's, with my mentor, Dr. Simon Harvey, where Ahmed also did the same fellowship just before me. So this rhythmic spiking is the one which is indicative of which tuber is epileptogenic. Okay, so this is EKG-like spikes. So after that, once you find that, you will find more and more of that. So this is a focal slowing, focal spikes in the same region, F4, C4, F4. So more of the same, more EEGs. By now you would have got convinced that it is all very localized. There is some slowing in the temporal also. So we have identified, okay, right frontal is the region. So now look at how many tubers are there in the right frontal. At least 3 different tubers were there in this particular patient in the right frontal. Okay. So there are other tubers in the right temporal, parietal, and the left side, it's all there. But we are not worried about that. We are worried about the right frontal. Okay, so we identified these 3 tubers, and then we take up the patient for surgery, intraoperative ECOG, with strip electrode over the tuber and depth electrode in the center of the tuber. Okay, so by center, we don't mean the geographical center. We mean that there is a dysplasia cortex we can identify in the MRI. So that is where you need to be. Okay, so and then we find this kind of spiking. Again, it is similar to the scalp EEG what you were seeing. So you have a EKG-like spikes, which is rhythmic 1 to 2 per second. So this is more of the same, rhythmic spiking in the electrocardiography in the operating table. Again, in the same region, same tuber. So another example. Unfortunately, in this particular patient, the strip electrode was more active than the depth electrode. So most of the times we find that the depth electrode is more active than the strip electrode. But either way, you got the information, you identified which of the 3 tubers where the active epileptogenic activity is going on. So then there was some reflection in the depth electrode also. Then we resected that tuber and we then recorded in the other tuber also. So we found, to our surprise, that also was active. So we removed 2 of the 3 tubers that we identified in the right frontal. So this has been very much hypothesized, developed in Royal Children's Hospital, this approach by Dr. Simon Harvey. I was fortunate to learn from him. And these are the 2 papers. The first one is in the neurology from our Ahmed, who did intrinsic epileptogenicity cortical tubers in the subdural monitoring. And then later I developed on that, and we could prove center of the epileptogenic tubers were the ones which were causing these. So we were looking for these EKG-like spikes. So for more details, you can refer to these papers. So this is what I was highlighting yesterday. For this kind of tuberous sclerosis, most of the epilepsy surgery centers in the world would do stereo EEG. At least in select patients, it may not be required. At least in select patients, I think I have operated 5 such patients. Tuberous sclerosis is rare, and the focal epilepsy, very localized epilepsy is rare. So I have done 5 such cases in the last 3-4 years. So I'm sure Sandeep also has similar experience of doing similar approach, and these patients are completely seizure free now. So another important concept, just few seconds, free of targeted seizure. See, in tuberous sclerosis, the problem is the infantile onset epilepsy, they have simultaneous 2 or 3 tubers firing, and they have simultaneously 2 or 3 seizure types. So you have to identify which is the problematic seizure type, which is the disabling seizure type, which is the seizure type that you are targeting in your surgery. Say, for example, I'll give you a non-neurology analogy, right? So there is a patient that comes to you with right ureteric calculi. You dealt with it surgically, right ureteric calculi is gone. The same patient has a small ureteric calculi in the left side. So will that mean the right ureteric calculi surgery that you did is a failure? No. So this was targeting the right ureteric calculi, that's all. The left side was not symptomatic at the moment, so doctor waited. So it is not a failure of surgery. Similarly, in tuberous sclerosis, when you targeted this seizure and you removed this tuber and that seizure is gone, so that is free of targeted seizure. Here, the angel outcome will not work because they may have subtle seizures from other tubers. So this we need to identify, this we need to counsel the family, this we need to understand this phenomena. In the video EEG, we are able to identify 2 or 3 different seizure types, and we need to be clear which one we are targeting. So that's the most important thing. With that, I'll conclude, and other questions I will take it later.
So now we have a third speaker, Dr. Sandeep Patil. So he's a pediatric epileptologist from Pune. So he's going to talk on recent advances in neuromodulation. Over to you, Dr. Sandeep.
Very good morning to all, and I will be brief because I think 8:30 the next session will start. And okay, my slides are here. So just to introduce, the impact of epilepsy is very high. Even there is a lot of unmet need and a lot of treatment gap is there. Okay, yeah. So the treatment gap, this is WHO data. And when you talk about drug-resistant epilepsy, the again treatment gap is very high. There are not lot of avenues available. So when we talk about our area, like Asia, Oceania, there are very few centers which can offer the treatment, like as Lakshmi showed, epilepsy surgery, and the neuro modulation is again out of the reach of many patients. Okay, so we are going to talk about neuromodulation. What are the newer concepts in neuromodulation? So this is the flow chart. I think at least this thing, this slide, you have to take it from this session. Like epilepsy, you have drug responsive epilepsy, which is very easy to treat, and obviously you're looking for a seizure freedom. But then if there is a drug resistant epilepsy, you'll have to think of surgery first. Surgery, if it is surgically treatable, go for surgery. If not, and I will tell you where the surgery is not possible, then you have to look for other modalities like a neuromodulation or dietary therapy. So I'll just keep this history of neuromodulation, but just to emphasize that the neuromodulation is going on for almost century, more than century now, and this VNS got approved in 1997, and then subsequently DBS and RNS also got approval by FDA. So how the neuromodulation works? There are few shared concepts like it deliver electrical stimulation to the targeted neural circuits, modulate excitability, synchronize networks, and reduce seizure propagation. While VNS acts indirectly by modulating brainstem and thalamus, RNS gives on-demand stimulation to the seizure focus after detection, and DBS stimulate the thalamus. So what are the indication for neuromodulation in epilepsy? Drug-resistant epilepsy failure of more than 2 appropriate anti-seizure medication is prerequisite. Those patients who are not a candidate for curative surgery. We have seen so many cases in the morning first two talks where you can offer the epilepsy surgery, but if that is not a case, non-localizable seizure focus, multifocal generalized onset, you think of neuromodulation. When there is overlapping with the cortex and fail or incomplete response to the epilepsy surgery. So neuromodulation can be broadly divided into two types, invasive and non-invasive. And invasive also you can divide them into intracranial and extracranial. In intracranial you have vagal nerve stimulation, while in extracranial you have extracranial you have vagal nerve stimulation, and intracranial you have RNS and DBS, and then you have non-invasive as well. We covered this thing in a neuromodulation workshop, so I will just skip that. So what is VNS therapy? VNS therapy is adjunctive therapy for partial and generalized seizures, where you implant is there is an implant which is put here. I'll just see. Yeah, this is a pulse generator, and it actually sends the impulses. So there are a negative electrode, anode and cathode, and it actually generates action potential that travels apparently via sensory fibers. Okay, and then I'll just go ahead. And this VNS therapy works by neurotransmitter expressions like increased noradrenaline, GABA, serotonin, and decreasing aspartate. It actually increases cerebral blood flow and desynchronizes ictal EEG patterns. So this is how this anti-convulsive effect comes with the VNS implant. VNS has a lot of study in the literature, and it's found to be very safe. The most common side effects what we see is a hoarseness, shortness of breath, sore throat, pharyngitis, coughing, infection at the implant site is another side effect which you have to look for. So this is like data from the literature which says that venous therapy reduces seizure frequency over the time. So the when you implant, the effectiveness can be around 30 to 40%. The seizure reduction, I mean to say, and if implant goes on for next 6 to 8 years, the effectiveness increases to 66 to 76%. It actually reduces the severity of seizures. So these impact you will see immediately. So the seizures are less severe. The patient's recovery time is improved. So suppose someone is having seizure for 5 minutes, he will have brief seizure to 2 minutes or 2.5 minutes, something like that. And if you have good anti-seizure medication along with the VNS, the effectiveness improves dramatically. So this is again a long-term outcome which shows better outcome as time progresses. So I'll just, this data is coming from US, where venous therapy reduces the economic burden of untreated drug-resistant epilepsy, and they have shown that the cost of venous is recovered within 1.5 years. So again, they have these insurance covered things which actually calculates the data, but in a country like India, we don't have that much economic data available, so it will be difficult to do this kind of study in our setting. Coming to the DBS, so DBS, there is a direct stimulation of thalamic nuclei. There are different thalamic nuclei which can be targeted. Globus pallidus, then you have nucleus accumbens, centromedian nucleus, or anterior nucleus of thalamus. So these thalamic nuclei, especially anterior nucleus of thalamus and centromedian nucleus, are known to exert modulatory effect on propagation of seizure activity. So that is how the plan is to stimulate the thalamus and desynchronize this seizure activity. So this is a landmark trial for DBS Sante trial, and it was started in 2003, and then the implants were done where there is a multilobar seizure onset, there's symptomatic generalized epilepsy, average more than 10 complex partial seizure per day. So there's very difficult cohort to treat. And this is the trial. What they did is they implanted, then they did randomization, and these long-term follow-ups are now available. So long-term follow-ups, what they say is around 65 to 70% of seizure reduction. Okay, almost 68% of seizure reduction over the 5 years. So that's a responder rate with a Sante trial. And obviously quality of life also improves with the DBS. So all these three devices has claim that around 60 to 70% seizure reduction over the period of time, long-term outcomes. This is a latest trial. So DBS done at centromedian nucleus of LGS in a patient of LGS. So again, this was done at older age, around 18 to 25 years of age, and few of them have undergone VNS plus calcium and had significant monthly seizure count around 79. And what they shown is around 3 months after the DBS, there is a significant reduction in seizures, and over the period of time, this is almost 1 year data, and they have shown that around 50% seizure reduction from the baseline. So this is again a new thing which is coming up, new nuclei for DBS, and will be exciting. Again, this another same nuclei targeted for the generalized epilepsy, centromedian DBS for the generalized epilepsy, and it also showed promising result. Briefly about RNS strategy involves implantation of electrode directly into or onto the epileptogenic zone. So you have to know where the seizure onset zone is, and then you implant that subdural or depth electrode with a stimulator. So it must be localized sometimes by invasive EEG, or you have to be very clear that where the seizure onset zone is, so that you can stimulate that particular area. So RNS is different from the VNS and DBS because here you are at a seizure onset zone. You can record the seizure activity. So that's one added advantage of RNS. You can record the electrocorticography, and then you can stimulate when the seizure is originating. So that's a kind of an advantage with the RNS. So it is a minimal invasive treatment option where eloquent areas are involved and a poor surgical candidates for bilateral seizure foci. So bilateral MTS is one of the indication which is coming to my mind, where you have bilateral mesial temporal lobe sclerosis and you put a RNS and then you record which temporal lobe is firing more than, whether it's right or left. And it actually helps you to individualize treatment, and there is a better understanding because you are getting constant intraoperative data. So it records more seizure than your intraoperative, because you have limitation when you do the scalp EEG or invasive EEG, you're doing it for 5 days or 10 days. Here you have continuous data. And some say that there is a positive effect of neuroplasticity because you are stopping the seizures are not propagating, and that is having the better outcome, long-term outcome. So with this, I will just show you one brief case how the neuromodulation works. This is a 15-year-old boy with history of hypoglycemic seizure on day of life 3. Seizure started at 3 years of age. So he had different semiologies: focal seizure, facial deviation to the right side, then clonic jerks, secondary generalized seizures. Now what he was having is predominantly drop attacks and reflex falls. So just want of the time, I'll just skip with this background history. Let's see. So there is a sudden sound now, and then he has a reflex fall. So So imagine these falls are happening while he's walking around or in at home. He's getting injured himself, and this boy was relatively well preserved going to the school. So for callosotomy, we usually do it when there is poor IQ. So in this boy, we were discussing what to do because palliative surgery has to be done. He was falling quite frequently. So this is the ictal EEG. It's a sudden fall and then almost generalized onset. And these interictal discharges where there is no
Dr.
focality.
Sandeep,
Yeah.
we have only 2 minutes.
Yeah, there is no focality. So you can see here, there is a bilateral and multifocal discharges. And the MRI was showing hypoglycemic changes. So you can see here, yeah. PET again was showing bilateral discharges. So he was implanted on VNS. So this is VNS device. I think this was Aspire and it was implanted. And this is seizure charts. This is pre-VNS seizure chart where he was having almost 4 to 5 drop attacks every day. And these were very disabling drop attacks. And after VNS implant, he had seizure-free days in between. So almost in between, he used to have 4 to 5 seizure-free days. So that was quite an improvement after the vagal nerve stimulation. So this is how he was before because protecting himself from the falls, and now he's back to the soccer field playing football, what he loves. Okay, so to conclude, effectiveness of neuromodulation. So initial seizure reduction at 3 months is quoted around 25 to 40% with all these three devices. Long-term seizure reduction is in tune of 50 to 76% for VNS, 75% for DBS and RNS. So we are talking about 50% seizure reduction. We are not talking about seizure freedom. It's just a 50% seizure reduction. And you can have seizure-free interval for at least 6 months, ranging from 18 to 20%. But consider these with add-on drug, which gives you only 4% seizure reduction, 4%. So it is actually good compared to the add-on drug. The one more benefit of neuromodulation is the SUDEP. So SUDEP rates are lesser when you implant the patients compared to the patients with a drug-resistant epilepsy and SUDEP. So, and it is comparable to epilepsy surgery SUDEP rates. So again, that's one area which we can look after. So this is where we stand now. The approved neuromodulation therapy, vagal nerve stimulation, anterior DBS, deep brain stimulation, anterior nucleus of thalamus, and RNS, closed loop. The effectiveness, the seizure freedom for more than 12 months is not there, only in a small minority patient, but more than 50% seizure reduction is achieved, more than half of treated patients. They are quite safe, so there are no major concerns, but there are no reliable biomarkers. Lack of high level comparative evidence is there. So we are still looking ahead, looking at new trials. So I think the time will tell us how effective this neuromodulation going to be in future. With this, I thank all of you for this patient listening. Thank you.
Thanks, Dr. Sandeep. Thanks for those interesting cases. I think we have 1 or 2 minutes. So can we invite some questions from the audience?
A brilliant session. Partho Rai, neurologist, adult, Kolkata. A question for Professor Ahmed about the reflex epilepsy. We think it's actually a network disorder. Did your patient have a lesion which you resected? I didn't quite remember. So
No, we're still sitting on the patient. She had hypometabolic regions over the temporal region, both mesially and over the superior temporal gyrus. And we don't know what to do with her.
yeah.
Because,
So I have 3 patients with musicogenic epilepsy from the Liverpool Philharmonic Orchestra who have a network problem. Now the question is, how do we study these networks? Sarat Chandra in his lecture online alluded to it, and I don't have a real understanding of how we epilepsy surgery specialists are analyzing the networks and their mathematical models to understand how does one influence the other? Because this is clearly a reflex epilepsy, that hypometabolic spot. I'm not so sure if it's contributory or it's causative. So that's a question I have for you. Do we know if because it's a reflex epilepsy at the end of the day,
Yeah,
by classical definitions?
I don't have an answer for that. I'm sorry.
Yeah, thank you. But, and regards your calcium and the two ureteric questions, I think the root cause is the hypercalcemia. That's why the person is having repeated calcium problems. So if we address remember we talked about ureteric calculi. So if we address the two underlying bases of something that's causing the tumors, then that needs to be addressed. And the downstream effects will keep manifesting here, there, this year, next year, and 10 years later. Thank you.
Thank you, sir. Thank you.